extremity peripheral arterial disease. And I think this is really, from my perspective anyways, it's such a helpful space to remember that outside of coronary artery disease, there's stroke, but peripheral arterial disease is kind of that, and excuse the phrasing, but the redheaded stepchild, I guess, the one that folks forget as part of the three legs of ASCVD. So lower extremity peripheral arterial disease, we kind of touched upon it in that last lecture on management of coronary artery disease. So here, I'm not sure why. Oh, there you go. It's always fun to kind of think about it. And I love this GIF because of potential of intermittent claudication, right? Now, although the injury for the specific actor in this GIF is something else, I think it's helpful to kind of picture what intermittent claudication might look like. So again, will I do any off-label? Probably. And then we're not getting any CME for this, so I apologize for that. Here, I think it's again important to think about the objectives of why we would do a PAD talk, and a lot of it kind of comes down to this. If you take out one of the legs on a three-legged stool, of course, it may tip, and I'm hopefully going to make some of those connections between CKD and incident PAD. Understand some of the impact that peripheral arterial disease on health, and as a single entity of ASCVD, but it's overall management, the risk markers that we should be aware of, and the therapies that you can order, that we order as well, and understand those principles of chronic thrombotic limb and acute limb injury management. So here, I think you know this probably better than I do in terms of kidney and heart connections and why it's important. But when you look at a cohort of chronic renal insufficiency, 21 to 74 years of age, I'm not sure what happened here to my slides. Anyways, the point being, and I will send out slides with all the data in it, is that there is a lot of heart disease that happens from kidney disease, and of course the other way as well is when you have a poor working pump and a lot of atherosclerosis that affects the renal arteries as well. But I think folks forget that even if you just start in the CKD space, in the nephrology space, it gets to be problematic. Oh, sorry, I guess here I am. But as you think about this in your world, there are a lot of folks that will probably suffer more from cardiovascular disease than ultimately get down to dialysis. And I think that's probably the most important point here, is that CKD is a strong marker and part of the pathophysiology of developing atherosclerotic disease, rather than that it leads ultimately to dialysis. So let me see here. Okay. You've seen this. We kind of talked about acute coronary syndrome, stable angina, then non-ST elevation MI, acute coronary syndrome, and then ultimately STEMI. But I bring this back because it's something that we're more familiar with, regardless of whether you work in cardiology or even in the stroke world. I think they kind of forget a little bit about the magnitude of atherosclerosis systemically. But it's always good to come back to this as we think of arterial disease. And is peripheral arterial disease that much different from coronary? It's kind of the same, but in different areas of the body. So here, as we kind of think of coronary artery disease, the STEMI and STEMI, again, ST elevation MI and non-ST elevation MI, where troponins are increased, and we know that this is from an atherosclerotic process. Here are, acute coronary syndromes, and that includes unstable, which is essentially like one step away from having an STEMI. And then ultimately, as you come through the peripheral arterial disease side, it's not that much different for the acute limb injuries and chronic limb injuries. You can think of that as kind of this ongoing angina in the legs, the claudication, and then ultimately, kind of this rest pain. It doesn't just occur with motion, but folks can begin to start having pain just at rest itself. And then here is the more kind of stable features of, okay, if I do enough exertion and I require more blood flow in these big muscle groups, heart being one of them, then you start to have these symptoms from loss of blood flow or not inadequate blood flow. You've seen this already, but kind of thinking back through, here's the aorta, and then as you head rightward, you're getting smaller and smaller. So coronary is here, but the femoral artery, and this is really an important kind of concept to keep in your head as you think of why there's a six-fold increase of coronary disease when you see femoral artery disease. And that's because any type of blockage here that's enough to obstruct a large artery certainly will overwhelm a smaller artery as you get further and further away from the larger arteries. Okay. And then we talked about coronary calcium as kind of a way to assess coronary disease before it happens, to recognize that here, even in folks that have no coronary calcification development, they may still have some atherosclerosis that is developing behind the endothelial wall. It's just then when you start to build calcification that you recognize microinjury is starting to occur. And these are the folks that are more likely to rupture, to have a coronary event. And then lastly, of course, severe coronary calcification. But is there a corollary to peripheral arterial disease? Is there a way to screen somewhat like coronary calcium? And yes, there is. So again, here again, I talked about how the coronary calcium will help predict an event rate. And I bring this up to you because, again, we focus so much on coronary disease, and that event rate's not small when you think of 13% versus 1% over a period of 8 years. Here, let's bring it back to how we screen this in the peripheral arterial disease side. And so here's an ABI. You're just putting cuffs on the upper arms and lower arms, or excuse me, lower extremities, and then you should have a 1-to-1. So that ratio really about, normal should be about 0.9 to 1. And then we have an upper range as well when it's 1.2. Then you think, man, that's non-compressible. It's got like pretty heavy calcium in there, or something's making that artery stiff, so that you see an opposite in terms of higher blood flow in the lower extremities than upper. So that's not normal either, but it's a different disease process. Excuse me. But as you kind of think about, normal to abnormal, here as that gradient, that ratio drops, in particular when it gets down below 0.9, then you have this abnormal obstruction. And to what degree? So here's mild peripheral arterial disease, kind of also, again, anything less than 0.9, where it starts to become abnormal here. And you see a degradation of the Doppler pulse waves. Instead of having this triphasic or even biphasic wave, it starts to become monophasic, and then it will flatten out the more disease you have, where it's not able to really get enough of blood flow to get these nice biphasic waves. And then until finally you have severe peripheral arterial disease. So the ABI is diagnostic of some type of obstruction there. You just don't know to what level the obstruction is yet. And so we'll go through a case that takes someone with ABI and then moves them through. And I think you'll be surprised that even mild ABI, quote unquote, mild peripheral arterial disease by ABI, when you do a CT runoff study, you can have a lot more disease than you expect. And then I wanted to bring this back because why? I mean, why should we do ABIs, and is it even prognostic by itself? When you look at this, these are folks that have PAD, or excuse me, no known peripheral arterial disease. So no risk factors, no ABI, and maybe even an ABI was done, but they're just asymptomatic. Well, when you take an asymptomatic person that has peripheral arterial disease, maybe they don't even have claudication, but they've been found to have atherosclerosis in their extremities. I mean, that's 1 in 5, right? Or 1 in 4, actually, having an event by 5 years. And these are, death, MI, stenting, strokes, carotid, etc. So, I mean, it means something to have peripheral arterial disease, even if it's asymptomatic. I mean, that's a clue that something's not right in these big pipes. So then when you look at it from an ABI, so that other was just diagnosis of peripheral arterial disease or not. It doesn't say to how we identified, but it spoke to symptom versus asymptomatic. And now when we come back to this top is essentially normal, in a normal range of 1.1 to less than 1.5. But this would be arguably kind of normal as well as you go to less than 1.1, but greater than 0.9. So these two are a little bit normal. You can see on their curves, they stay pretty close together. I mean, the event rate is still, almost 10% by 5 years. So something about them is risky. Of these 72, these women that were older, 72, 58%, I guess, there were men in there too. But because you decided to do an ABI, it's because they had risk factors. And so they are not free from event, but they're much more free than if you do an ABI and suddenly just in that mild range of under 0.9 to greater than 0.7, again, about a 1 in 4 event rate in that next 5 years. So whether they have symptoms or not, that's problematic. And then if you do an ABI and it's in that mild, you should be doing something for these people, because in the next 5 years, 1 in 4 of them are going to have some type of event, which includes death. Of course, this is what we think about when we think of peripheral arterial disease. We're like, oh, it's the amputations. That's not good. Of course, it's not good. It's major disability for folks. When you're losing a limb, it's hard to get about. I mean, we kind of think about that, and we're like, oh yeah, it'd be really hard to walk around with one leg, but it increases their disability factor for other stuff, because they're not as active. Now they have to have help, where if they live on their own, or if there's some social determinants of health where they don't have access to other things. Now they have even less access when you start to experience loss of limb. So this is the Fourier trial. We were part of that here at Intermountain. I was one of the sub-investigators. But the Fourier trial was of the newer injectable. I shouldn't say they're newer because they've been out since 2015. But in any case, the Fourier trial looked at these individuals that had an ASCVD event. I mean, we knew that they'd had a heart attack in the past, or they'd had stenting, etc. And their fasting LDL cholesterol was just above 70, fasting triglycerides less than 400. And this is probably, a group of our usual patients, 40 to 85 years of age. And then they looked at the group with peripheral arterial disease. Now, 27,000 plus patients, and half, of course, randomized to Repatha, evolocumab versus placebo. But of that, about a little over 10% had symptomatic lower extremity peripheral arterial disease. And then they looked at those with lower extremity peripheral arterial disease, but had no prior MI or stroke. So they came in through being ASCVD because of just PAD. And this is kind of the breakdown here of that group. Well, what you find, and this is astounding to me, because as you look at this, I don't know why that's on there, but as you look at this is peripheral arterial disease. So we think of ASCVD, but with peripheral arterial disease, these folks, they came in through the study with just stroke or heart attack. And that's risky. But this was that group. If you had peripheral arterial disease, look at the difference in risk. The hazard ratio was 81% more risky when you had peripheral arterial disease, as opposed to your run-of-the-mill coronary disease or stroke. So we're not diagnosing PAD enough, but when you have PAD, your life expectancy and your event rate is so much higher. On this side it strikes you again that when you have PAD and then you have a stroke or a heart attack, look at the astronomical increase in your event rates when you have peripheral arterial disease and then you have a stroke or a heart attack, which is really what you're going to have with PAD, or PAD alone versus MI or stroke without peripheral arterial disease. So again, peripheral arterial disease by itself is a big jump in risk for events over folks that have just had a history of stroke or heart attack. But then if you have PAD and have had a stroke or heart attack, and that's early, like this is 6 months here that it just separates out. Same thing back here. That's how at risk. And when you're saying 1 in 4 are having an event by 5 years, this, they're having it not just at 5 years, they're having it at 6 months from the time that you diagnose them or are paying attention to them. So it's helpful to treat them, of course. And this is where I think it's neat to look at these studies, because you're like, okay, MI, stroke, when we give them evolocumab, the Repatha on top of statin therapy, we're like, oh, good, we reduce, their risk by 1.4% for all of them, and there's a relative risk of about 15. But then you look at the peripheral arterial disease, folks, how much more beneficial is it if you have peripheral arterial disease? Well, it doubles the risk reduction when you target them, when you pay attention and treat these people appropriately. You have a better capability of reducing their risk, and yet still, they have a higher risk than heart attack and stroke alone. So we're just not doing enough for these folks, but it tells you just how complicated peripheral arterial disease is in the world of ASCVD. This is MACE or male. We think of MACE as major adverse cardiovascular events, so strokes, heart attacks, cardiovascular death, revascularization, but male is major adverse limb events, so amputations or partial amputations or stents in the legs, etc. And you can see that with and without PAD, again, when you apply therapies to this group, there's such a large outsized reduction in risk if you're paying attention, diagnose people with PAD, and treat them. So that's probably the main message here for everyone is please keep it in mind that CKD leads to ASCVD, but one of those features is PAD, peripheral arterial disease. It's not just heart attack or stroke that we're worried about. And so, assessing them appropriately is important. So here, I think it's important to have a high index of suspicion. Here's the partners trial. And this was a trial that was 20 years ago. And essentially, they just took people who were 50 to 69 years of age with a history of smoking or diabetes, and they were evaluated for, baseline history, and everyone got an ankle brachial index. So ultimately, about 6,400 were enrolled. And it's so interesting because peripheral arterial disease was identified in about 30% of them. So just smoking or diabetes, 30% of them have peripheral arterial disease. And 44% of that group of people who had PAD were only PAD. But remember that the riskiest folks are those that have peripheral arterial disease and cardiovascular disease. So if you have PAD, you're more likely to have other stuff, and your risk of mortality and events is so much higher. There were really only 24%, 1 in 4, that had just cardiovascular disease, where they didn't have any PAD, and about half, did not have anything, didn't have peripheral arterial disease or cardiovascular disease. And what I would say is this: the message is not that, well, I shouldn't screen them because half of them don't have events. You should screen them because in the general population, if you screen people without smoking or diabetes, the percentage that have cardiovascular disease is like even lower. So you have to screen the right people. And that's what this message is that if you have someone between 50 and 69, have diabetes, smoke, please consider an ABI. Like, don't just consider it, recommend it, because that's actually what the guidelines would say. But the sad part is only 83 of the patients, 83%, were aware. They had a diagnosis already of PAD. only 83% of them were aware. There were a good 27%, maybe 1 in 3, that were like, I have PAD, what? And then only 49% of their clinicians, despite it being in the EMR, less than half of the clinicians treating these patients, the ones recommending therapies, the ones that progress therapies to help reduce events and loss of limb and life, only half of them knew that the patient had a diagnosis of PAD. So as you're kind of screening and doing pre-charting, please pay attention. And it's okay to do a quick search. I do it all the time to see if there are things that I might be missing in the chart, because some things don't travel forward from note to note, and other things, of course, we get the chart lore as well, where there's a diagnosis that really doesn't exist. But here, PAD prevalence, how prevalent is it? About 8.5 million. And I would say that that's actually low. Later epidemiologic uh, um, reports suggest that it's closer to 13 million. So like 30% higher in those that are greater than 40 years of age. And so who should you be looking in? Folks, of course, if they're over 70, you've lived long enough, you can build atherosclerosis. And the sad thing is we're always taught, well, it's claudication. Claudication will tell you. But remember, asymptomatic PAD, 1 in 4 of them will have an event in the next 5 years. And only 10% really have classic claudication. So it's a good place to start. Like if you ask them, how far can you walk? Oh, I can walk about, maybe a mile. Do you ever have to stop? Yeah, my legs get tired. Well, that classic kind of conversation is only 10% really experience that. So be highly aware that these are going on. And then it's variable in terms of how they present, how they describe that. If you think chest pain is a difficult thing to sort out, claudication is even worse. And so half of them don't even experience any leg pain, but 1 in 4 of them will have some type of event, including death, in the next 5 years. So they'll experience some type of symptom. It may be the last symptom they present with. And sorry, I did little pie charts here to kind of give you a sense of the percent within a whole of folks that experience anything. And I think it's just so stark when you think of PAD and how people experience it. It just, they're not going to be able to tell you. You really have to have a high index of suspicion here. Okay, so we kind of know this. These are the risk factors and treatment targets for peripheral arterial disease. It's pretty similar to stroke and heart attack in terms of management, other than there's an addition of like prescribed walking is kind of part of this. But it shouldn't be a surprise in terms of smoking, diabetes, age. I, I don't know if you've heard of hyperhomocystinemia. It is still a risk factor, but very few of us order that anymore, because in the order of things, it's really a niche kind of lab to order. You can do it, and I did it a lot back in 2004, 2005, when it was kind of like the new biomarker du jour. But by 2007, 2008, we really weren't doing it anymore. Screening, again, who do you screen? Those that are expressing claudication, you probably should screen them, right? But remember that in the partner trial, that of those that had PAD, only 2% had any symptoms at all. And we talked about 10% symptom presentation. It's highly variable, and I don't think we're very good at eliciting symptoms. Partly because patients get confused as to what you want. Like, what are you asking me? And so I'm pretty upfront, and I'll explain what PAD is and how it can cause symptoms. Then I'm like, that's what I'm asking for. And like 1 in 4 people die from this or have a problem within the next 5 years. That's why I'm asking. So do you or do you not have these symptoms? And that kind of clarifies things a little bit. You might get a lot more false positives, but that's why an ABI is helpful, right? So age greater than or equal to 65. If you're younger than that, 50 to 64. If you've already had diabetes, that's probably something to think about. Or excuse me, atherosclerosis. But diabetes, history of smoking, hypertension, or a family history of PAD, they should get a screening. Those less than 50, if they have had diabetes and one other additional risk factor like smoking, then certainly that'll speed up atherosclerosis. So then again, individuals with known atherosclerotic disease, I am not good at this. So I'll just be forthright, transparent that I treat folks with already coronary disease and carotid disease. You might see some renal artery disease in yours or AAA. Those are folks that it shouldn't be considered. We should send them for an ABI, and I'm not doing that often enough. Honestly, less than 10-15% of the time. So I need to speed up my screening as well. Here, again, it's just visual, same thing, same message is who's at increased risk of peripheral arterial disease. I think it's helpful to see it in visual instead of just text by itself. And then if these are something you find while you're doing a nephrology visit, if you happen to hear claudication or you've talked to them and they're like, yeah, I got pain in my legs. But then the physical exam findings here is, of course, if you're checking lower extremities, if there's a drop off in pulses or you hear a vascular bruit in the neck, of course, non-healing lower extremity wound or gangrene. And then, so one of the grossest things I ever saw was when I was at the VA. One of our patients I was visiting with was homeless and had not taken off his boot in probably a couple of months, and taking it off took some skin off as well. Actually, bone was uncovered. So, and I think Sid Biggs has an even worse story than that. In fact, anyways, I'll let him tell you the story if he hops on at some point. But here's the ABI again. Just bringing it back. You want either normal 0.9 or greater up until 1.4 or 1.5. And there's another disease process. And then certainly anything less than 0.9 should make you super suspicious that you should send these folks to vascular surgery, not for surgery, but they're better at sorting out the rest of it. If they do CT scans, they not only do surgery per se, but they do a lot of endocatheter techniques as well, including drug-coated balloons, etc. So here again, traditional treatment comes out to smoking cessation, optimizing the diabetes control, blood pressure control. I mean, we all know these things, but it's helpful to recognize it's the same as what we think of in traditional atherosclerotic cardiovascular disease. But I added the plus sign above because of the structured exercise program. It is something we have here at Intermountain, and you should be considering it. But coming back to the traditional ASCVD risks and how do you manage it? Smoking cessation. I don't know how many of you are familiar with using like varenicline or Chantix or Wellbutrin, etc. But they are effective. And we had a speaker come to us about a year ago that it really kind of helped sort it out for me that we may be under treating based upon the amount of nicotine that folks are on. We may be under treating them, and so feel free to kind of bolster the dose and keep it higher for a time to overcome the nicotine that they have been having in their bodies. And then optimizing diabetes control, I think this should be near and dear to your kidneys. SGLT2 inhibitors, I like the term flozin and flozins, instead of, empagliflozin, dapagliflozin, but using the flozins, kind of like statins, is helpful, and it's kind of catchy to me, but it also kind of makes you think, okay, kidney flow, it's a flozin, something that will help improve kidney health as well. But GLP-1s are important. I don't know how familiar or how comfortable you are with them, but if not, work with us. We're more than happy to work through therapies with you in our preventive cardiology clinic. But I would say endo and PCPs are very familiar with using GLP-1s. We've become very affluent as well because of cardiovascular trials now in the GLP-1 area. And you may be keeping track of the FLOW trial, which was stopped early because of top line results that demonstrated it was effective. I think that might have just been reported out, but the flow trial was semaglutide. And then blood pressure control, of course, in our space, both cardio-kidney, I think RAS inhibitors rule out here, not rule out, but rule in general as a first-line agent for us in terms of protecting the kidneys and the heart. And then lipid-lowering therapies, we kind of discussed at the prior meeting as to what ranges and what are the first-line goals. So greater than 50% reduction from baseline, and then for many LDL targets of less than 70. But honestly, most of our patients that you and I share are very high risk ASCVD, and the LDL target is actually less than 55 milligrams per deciliter. So here's the structured exercise program. It can be supervised in terms of someone watching them in a hospital or outpatient setting. So, standalone or structured community or home-based exercise program. I'll be talking with a group that do virtual cardiac rehab, and this is one of the things that they offer is a structured exercise program. Then you can have kind of well, this is the benefits of a supervised walking therapy. So we'll just kind of move forward here. I mean, what's the deal with walking? Is it important? Is it not important? What's going on? If you can get folks to get to that uncomfortable sensation of claudication, it triggers neo-intimization and neovascularization. So that you can actually build collaterals as you work people through a supervised walking program, both in the heart as well as in the legs. So neovascularization can occur, but really it helps patients to also tolerate claudication better. But most of these are 12 to 26 weeks. I've placed, whoops, there. That's the actual order set. If you look up PAD rehab outpatient evaluate and treat, they'll do it. They'll contact your patients and walk them through literally walk them through a PAD supervised treatment. But it's kind of neat to think of like what it does. It increases walking distance, and it might not seem like a lot. So increased by 180 meters. That's like nearly 2 football field lengths. And if you can imagine someone that doesn't leave the home because they can't even walk to the mailbox, or they can't walk around a Walmart, 590 feet is a huge boon to access. It allows them access to many more things, because there are a lot of folks that just choose not to go out to games, to events, etc., because they can't even walk from the parking lot to the venue. So I think it's important to think about that. Nearly 3 of the 4 patients in this meta-analysis reported at least 50% improvement, and then 1 in 5 had 100% improvement. And that's pretty neat. It's cool to think that, okay, this is a therapy that can improve our patients' lives. I want to flip that a little bit and think of pharmacologic treatments. Like we think of, oh yeah, it's easy to think of a statin in peripheral arterial disease. Hopefully I've just taught you that. And then cardiac disease, when we use a statin. You know how many people we need to treat with a statin to actually get efficacy? It's about 80 people that you need to treat, number needed to treat to reduce an event. Here, the number needed to treat is 4 to get 3, or 4 to get 2, and 5 to get 100% improvement. Because remember, we're saying that we've reduced risk or events in the statin side of things 20 to 30%. So it's pretty cool to think of something that physiologically makes sense and improves quality of life. Here are the standalone versus part of an established cardiac rehab program. You can do just direct supervision versus a supervised program that's structured. Here, they just watch them, go ahead and come in, walk on our treadmill 30 to 45 minutes, or just intermittent bouts of walking on your own. That's moderate to maximum in producing this discomfort in the legs. And then you alternate with periods of rest. So warm up, cool down. And so patients can do this on their own or as part of a structured program. They're self-directed with guidance. Now we're hearing that there's virtual components to this. So please think about uh, first doing an ABI to screen and then sending them to structured or supervised exercise therapy. Who can get these therapies? Be it you're saying that these are awesome and we should have them, but who can be covered by that? And most of our private or commercial insurances follow CMMS, and so here's the coverage for Medicare and Medicaid. Has to be prescribed. Unfortunately, cannot be prescribed by APPs. We can supervise it, but we can't prescribe it yet. That it's being worked on the federal level, but physicians. And then prescribed exercise 3 times weekly for 12 weeks. Additional 36 can be done, and then these can be taking place in a physician's office or outpatient hospital affiliated setting. They actually do cover virtual as well at the same pay. So there you have it. And then, we talked about antiplatelet therapies. As you know, I'm partial to P2Y12 inhibitors, so I like clopidogrel. But there's 2 trials, the Voyager and the Compass trial, that would suggest that adding rivaroxaban, direct oral anticoagulant, but not at the AFib dose or the PE venous thromboembolus dose. That's 20 milligrams for AFib, and then 15 15 is the reduced dose if they have creatinine stuff, and then 10 is for chronic VTE PE. This is 2.5 twice a day, and they added it to aspirin. I actually do it with clopidogrel. Again, that's kind of off label, and I'll make that transparent now. The labeling is rivaroxaban 2.5 with aspirin. And then claudication reduction control, cilostazol, if you haven't ever prescribed it, and if you haven't been practicing as long as I have, then you probably haven't. Cilostazol is definitely kind of gold standard, actually, for claudication. But the data is kind of here and there. You can use that 100 milligrams POBID, and make sure to let them know, take it 30 minutes before meals or 2 hours after. And then that combined with supervised exercise program, you might get more than that 2 football fields of length. And also something that they continue on. And then, of course, flu vaccine. It's important to protect from cardiovascular events in these patients. So I think, look, there's a lot of therapies. You saw my hopefully you saw my funny on meds and the worry that we give folks too many meds. We do. There's a lot of therapies here that we can provide. And I kind of think, I wish we could combine them all into one convenient dose. So the little cartoon on the left here, and by the way, that's a rectal suppository. And then on the other side, each capsule here contains your medication plus a treatment for each of its side effects. I mean, these interact, they have side effects. Not everyone experiences those side effects, but nonetheless, we have to remember that it's not just about set and forget, but you have to elicit, what are you thinking as, patient X? What do you think we should be doing? So here, I just wanted to give you a case, and she's actually up on my other screen. But this is not the same age anymore, etc. But here's a 61-year-old woman that was sent to us to establish cardiovascular care. It was a direct referral from our vascular partners. She's a longtime smoker. From age 17 to 58, which tells you she quit just 2 years prior. But a 50-pack year history, she kind of fits right in that screening area. But that's not what uncovered this. She has hypertension and a history of serially elevated LDL cholesterol up to 150 milligrams per deciliter. So it wasn't low. Her LDL cholesterol was already high to begin with, and it's been that way for some time, since 2007. What happened was she had dropped a weight on her foot, and it just was not healing well. They decided to go ahead and do an ABI, and you can see here the ABI was 0.77 on the right. And so if you remember, 0.9 and above is normal, less than 0.9 is in that mild area, but that left is kind of in that normal area from 0.9 to 1.4. So abnormal on the right, normal on the left. But let me give you a prehistory as well. She had been having pain in her right leg for nearly 15 years, and had been diagnosed with sciatica, had actually even gotten a lumbar spine laminectomy, and twice, and it did not treat the symptoms whatsoever. Okay, all right-sided, and so. Anyways, she gets this AVI, gets sent to vascular surgery. They do a CTA runoff, and so where would you think the disease is? I said the right side is abnormal, and the left was normal. So kind of think through that. The more common sense would be it would be on the right. Well, it was the right common iliac, pretty high up actually, had a 90% blockage in that artery. But the left wasn't absent disease, it just wasn't obstructive disease. She had a left common iliac of just under 50%, and that persisted down to the left distal popliteal, less than 50%. Now, she didn't have symptoms, but I did tell you that it's really only 10% that manifest any symptoms at all. She did have on the left side. On the right side, she had symptoms that was this poor healing wound, and her other symptoms people thought were sciatica. So she goes forward and gets a stent. They deploy this 9 by 38 millimeter stent to the right common iliac. And I will tell you that I followed up on her with her on her symptoms on the sciatica. And she said, it's funny, but I don't experience sciatica anymore. And I said, because it was never sciatica. You had claudication and it was manifesting as sciatica. And it kind of like, thank goodness you dropped the weight on your foot that led to this workup. And ultimately the treatment was getting this right common iliac stent. But we do a lot to folks, but we're sniffing down the wrong track. In any case, her medications are amlodipine 5 milligrams, losartan 50, atorva 80, and clopidogrel 75 milligrams. And so, we get her vitals, 132 over 80, BMI is 36, she weighs 100 kilos, heart rate's 80. And then you get these labs here with total cholesterol 176, HDL is 59, and they had added the atorvastatin, so she dropped to 103. It's kind of a suboptimal response, actually, to atorvastatin 80, and her non-HDL is 117, triglycerides 72. Me, in preventive cardiology, I decided to add a few more things to kind of clarify some of this risk. And an ApoB was 78, which is fine. HSCRP is elevated. Anything above 2 suggests inflammation. So she's at 8.4, but her LP little a was normal. It's 20 or 2, excuse me. It's actually supposed to be 21, but it's still in the normal range. A1C is 5.9%, so that should kind of, tick some bells. And then glucose 108, which, wasn't fasting, it was random, but the A1C kind of tells a story. And then creatinine was 0.85 with EGFR 74. Now, I because she hadn't really been diabetic, although I should have gotten a UACR at that point. I did not. So let's talk about this. I mean, you've now had 2 kind of presentations, one coronary disease management, here's peripheral arterial disease, and there's no wrong answer here. I'll tell you what I ended up doing, but what are your thoughts? Like, what would you do in nephrology to optimize her risk? And does she have risk? She probably wouldn't be referred necessarily to you, but what if she showed up to you first? Any thoughts as to what you would do? I mean, you're welcome to type in the chat, or if you just want, you're like, yeah, just go forward. Let me know.
Well, she has an elevated A1C, nothing that we would consider as full-blown diabetes, but we could consider an SGLT2 for kidney and heart protection and possibly a GLP as well. But I think that might be too aggressive given that it is just 5.9, but working with her for better sugar control. What are your thoughts about that?
Yeah,
Yeah.
I think I agree with that. And yeah, definitely getting a UACR is important here. Um, but yeah, maybe just start with SGLT2.
Yeah, I mean, I like that, and honestly, the thing that I would avoid saying is aggressive. I don't think it's aggressive. I think it's coverage.
Okay,
I, I,
okay.
from my standpoint, the problem is coverage, and I kind of use glucose and A1C as an excuse to use appropriate therapies because here her BMI is 36.
Yeah.
And we know that SGLT2s will reduce some weight. It's not as effective, obviously, as GLP-1s. And so I mean, I guess you could come at this from an obesity standpoint. You'll never get coverage there with Select Health. But then, the other side of the coin is the A1C as a way to try to get her on, try to sneak it on, because the data is this. Look, we know SGLT2s for kidney protection. We know that for reducing heart failure, risk. With two trials now, the DAPA MI, which was just at ACC this 2 weekends ago, and then at AHA was no, I'm sorry, that was Impact MI, empagliflozin and MI, and then DAPA MI was at AHA in November. None of them reduced cardiovascular, like atherosclerotic events, but they, like we would expect, heart failure events were reduced, kidney disease events were reduced. So I like SGLT2s here for the glucose, for the kidneys. And by the way, you probably have seen this, but there's data there and mechanism that shows better blood pressure control. It's a mild diuretic, and often we will see a drop in blood pressure as well, anywhere from 5 to 10 millimeters of mercury, like a low dose hydrochlorothiazide. But you get even more benefit than what a thiazide would give you. And then BMI, it might affect it by 1 to 2% weight reduction, up to 3%. But I like the GLP-1s because of the recent data from the SELECT trial, which is in non-diabetic patients that had ASCVD. Admittedly, it was coronary, but I've already told you that PAD is even worse for coronary events and risk than coronary disease by itself. So I like the SELECT trial data there. I like the recent FLOW trial that looked at semaglutide and kidney protection. We've seen that all across the trials for GLP-1, also protecting kidneys. And then here, I mean, looking at weight, and she's got metabolic dysfunction. While we won't call it florid diabetes, and I hate that, by the way, I hate that. By necessity, ADA has set that at 6.5, but it's a continuous variable. We just set it there, and I think here we need to just kind of get closer to thinking metabolic dysfunction because she has that. So I like those. I hope that kind of my thought process anyways. I hope that makes sense, but I love starting with an SGLT2, and her getting a UACR would be important. Of course, you're talking to preventive cardiology, so that atorvastatin is not enough. If I had my the president gives me like full license to just use, it's going to be healthcare for everyone, you just use what you need. And so what I would say is I would love a GLP-1, but absent that, atorvastatin 80 is just not enough for this LDL cholesterol. She's very high risk. And I would, consider adding ezetimibe, but you're only really going to get about a 20% reduction. So that might get us to 70. I would add a PCSK9 inhibitor. So I talked about the Fourier trial. Repatha would get her LDL cholesterol to about 50, maybe even less, depending on how well she responds to it. So Repatha at least saves from having a daily pill if we can afford it. I I would say we could probably maximize the ARB, or maybe switch her to a more potent one like olmesartan or candesartan instead of losartan. I don't know that if she then became hypotensive, I'd get rid of the amlodipine and still maximize RAS inhibition, and then hopefully we could get an SGLT2 on board. The other thing that I discussed a little bit with you earlier is the COMPASS and the Voyager trial. So she's on clopidogrel 75 milligrams, but the Voyager and the COMPASS trials used aspirin and then rivaroxaban 2.5 milligrams POBID. And if we could, and it's a lot of therapy to add to someone, but I think it would be a great addition in terms of optimizing risk. So those are the things that, for me anyways, it's easy to say, okay, lipids, here she's got metabolic disease. I would love to see an SGLT2 inhibitor. If I could sneak a GLP-1, I'll do it, and then consider rivaroxaban. And I think we'll span the different ways to optimize the risk. But the thing that I haven't necessarily talked about is, does she need supervised exercise therapy? And the jury's kind of out here because she's absent symptoms now. But what I have done is, when I talked to her, I said, you need to be active. And she says, I am already more active. It's been years. It's been years, 15 years since she's been able to walk without any pain, and she's doing it on her own. So then the question is always begged, like, how much more should she be doing? And that's where we've been following up and seeing how much activity she's been able to incorporate in her day. Do we feel comfortable with this case? Does that make sense?
I have a question. You mentioned aspirin.
Mhm.
Did you say aspirin would be with rivaroxaban? It wouldn't be with the clopidogrel, correct?
Yeah, so that's a good question. For FDA label would be aspirin 81 with rivaroxaban, but I will say it's one thing to go with FDA label, but I'll go with the data, which is that P2Y12 always beats aspirin for less bleeding and similar efficacy, if not slightly better. And so what happened was the Voyager trial and the COMPASS did not use clopidogrel. They used aspirin. So that's why the label is aspirin and rivaroxaban. But through every trial, if you're going to go head to head between clopidogrel P2Y12, so prasugrel, ticagrelor, against aspirin, it wins out. It's better in terms of less bleeding, and it's better in terms of reduction of events. So I like that with rivaroxaban. But if you're going to stick to label and protect yourself, BYA wise, if you don't feel comfortable doing a P2Y12, then aspirin and rivaroxaban is what the label would tell you.
Okay, thank you.
Yeah, yeah. So here, let's see. As I go forward, this is really the summary. 1 in 3 patients age 50 plus that have a history of smoking or diabetes. I mean, that's the prevalence, right? If you're 50, you have a history of smoking and diabetes. That's our case. Symptomatic PAD, it's just not common. It's really not that common. Quite a few folks, kind of like AFib, actually, they're just not they're not symptomatic at all. But if they're asymptomatic, like 50% of them are, and they happen to have peripheral arterial disease, it's 1 in 4 that will have an event in 5 years. We need to be better at screening for this. And so ABI, it's really relatively cheap, and it's a sensitive screening tool. It's about $80 for screening, and it's worthwhile. If you identify, then you're going to save a life. And if it's negative, it's negative, and probably consider doing it again in 2 or 3 years. And then PAD itself, remember, it by itself, it's bad. By itself, it's bad, but it's an amplifier for those that have MI and stroke already. Then you're looking at almost doubling risk. So let's talk.